Yeah, okay, all right. Thanks, Sonny. So I'll start now. I mean, you heard about the good stuff from Professor Briggs. I'm going to tell you about some of the bad stuff about being a clinical manager or a leader. You'll spend quite a lot of your time dealing with complaints and problems, inordinate amount of time. Next. So Dale Carnegie, American author, How to Win Friends and Influence People. This is what he said about complaints. And this is the Sir Lancelot Spratt view of complaints. You know, the typical sort of patrician, arrogant doctor, knowing that patients don't know anything and the doctor knows best. Now that is dead and buried, really. You can't think this way. Next. It's probably worth reminding you of what the GMC says about how you should behave and how you should act when there's a complaint against you. So I'll just give you a second to read that. Next. So the really the temperature changed on complaints with the mid-staffs inquiry, which was getting on for 10 years ago now. Probably it was 2013, 2014, when this hospital was investigated. They had poor outcomes, high mortality, and a lot of complaints. And there was a big investigation as to what was going on in the hospital. Next, and this was by Robert Francis QC. And complaints were a major issue and the way they were dealt with in this hospital. And it was recognized that Ms. Staffs wasn't alone, and this sort of behavior was going on in a lot of trusts up and down the country. Next. This was what Don Berwick, who was the NHS safety lead, I think, had to say about the mid-staffs inquiry and how you should look to be dealing with complaints. You should be honest, open, and truthful with patients when there's a complaint or there's a problem. Next. So just to give you what I think is a perfect example of this. This is really one of my surgical heroes, Mike Freeman, the late Mike Freeman. He died a couple of years ago. And he was probably with John Insall, he was responsible for the invention of the modern knee replacement. And I remember being impressed. I think I was a houseman on his ward round, and there was a patient who, unfortunately, the swab count be wrong, and on the post-op X-ray, he realised that there was a swab in the femur. And he went up to the lady and said to her, "I'm very sorry, madam. I've cemented a swab into your femur. I'm going to need to do another operation on it. And if I were you, I would sue me." Of course, she didn't, but it was a very good example about how you should be open and honest. People understand that we're human and that even doctors can make mistakes. Next. So it's probably worth considering this slide, what a patient wants out of a complaint and what an organization ideally wants out of a complaint. And they're not necessarily the same things. But each organization should work out a way of responding to complaints that helps the organization and helps the patient as well. You know, the patient will be, of course, very keen on getting an apology. You know, that's not necessarily something the organization wants to do all the time. But any complaints procedure has got to produce a reasonable process for both patient and organization. Next. So this is a busy slide, and I don't want you to read it, but this is the title page of our trust complaint policy. And all I want you to see is look at the bottom and see that this complaints policy extends to 28 pages. Now, trusts will have slightly different complaints policy, and it probably is a good idea to read it, but it's extremely exhaustive. And again, this is the result of the Francis report. Next. So this is this sort of process we have in our trust. So within 24 hours, the patient will get a call, and the timeline is laid out here as to when the investigation needs to be done and when the response needs to be done. Next. Complaints are graded as to severity from, a sort of complaint, I've been waiting too long on the waiting list, that is dealt with routinely by a fairly junior member of the admin or secretarial staff, to a serious incident which needs exhaustive investigation, possibly external investigation, and a response by the chief executive. And each complaint, when it's logged, is graded, and the procedures according to how severe the complaint is. Next. So this is probably a useful slide, and it's useful if you're responding to a complaint as to how you should do it. And in fact, if you're looking to be leaders, clinical managers, it's quite useful anyway, as a guide to how to write an email. Particularly the, don't make derogatory comments about anyone. Stick to the facts, and don't use emotional language. When you're a clinical manager, there will be a lot of things that upset you, a lot of behaviors that upset you, and you're going to have to respond to it. And when you're writing an email, I think it's a very good idea to leave it in drafts for a day or two. And what I invariably do is, when I come back to it, is I will take all emotion out of the email, out of the communication. It will be much more powerful. Next. The way we do things in our trust now is that it's not necessarily a consultant that's involved in the complaint that gets to meet the patient. So you may be asked to have a complaints meeting about a complaint that's nothing to do with you. And my advice about that, is do your homework and read the notes. Now, most notes are electronic, not like these paper ones, but the worst thing you can do is to go into a complaint meeting unprepared, not quite knowing what the complaint is, not knowing what happened. So do your homework. Generally what will happen is you'll be meeting with a patient and their representative, and you'll have a member of the hospital management with you. Next. So this is, I think, an important quotation, and your lives as doctors will be made much easier if you minimize complaints. Complaints do narrow your coronary arteries. It's really well worth avoiding them if you can. So I have some advice. Next. So this is just simply pulled off the latest communication I had from the liaison service that deals with complaints. And as always, the top one, the most common cause of complaint, is problems with communication. I'm going to look at some of those. The other one I would draw your attention to is the one that's second from bottom, and that's values and behaviors. Now, in the USA, where all the hospitals are private, if a member of staff, there's a complaint about value and behavior and it's upheld, that member of staff, even if it's a top surgeon, even if they got fantastic results, will be sacked generally. The NHS is much more difficult to get sacked, but complaints with values and behaviors are viewed rather differently from the other ones. And certainly I'm the clinical director, and any value and behaviour complaint against a member of medical staff, I would have to interview the member of staff. And it's viewed quite seriously. But the moral of this slide is make sure your communications are good. Next. So here's an example of poor communication. Now, if you have a new secretary, it's probably a good idea to check what they're typing, certainly for the first few clinics that you do. This is one from my colleague who had to apologize for typographical error. The other one he told me of his, which I rather like, is patient complained, didn't like the fact that it said that he'd twisted his ankle and stinks of cider. And in fact, he twisted his ankle playing 6-a-side. Next. So, you know, we had to respond to complaints, and this was part of the response. This was a surgeon who was trying to communicate to the patient that probably there was not going to be a good outcome whether the patient had surgery or whether the patient did not have surgery. Unfortunately, what the surgeon said to the patient was, "You're fucked if you do, and you're fucked if you don't." Well, don't use language like that. It really doesn't work, and I'm not surprising there's a complaint about that sort of thing. Next. This one I love. This makes me laugh every time I see it. This was an advice sheet given by one of our doctors for patients with back problems, and we got actually more than one complaint about it for fairly obvious reasons, but good advice really. Next. Most of you are relatively recently qualified. We didn't have any communication training when I went back to medical school, so when I was in medical school a long time ago. And you'll have had communication training, but this is the sort of stuff I tell my medical students because, you know, I do find it useful, and as a clinical leader, you will recognize that it's the same people that get all the complaints. And these are my top tips for avoiding it. You know, making the patient laugh is very useful. I always try and do it. It makes them happy, and it makes them feel good about seeing you, and they're much less likely to complain about you if they feel good about seeing you. Quoting back is a little trick. You know, if someone's giving a history, so they get, you know, their knee hurts when they're running, let them finish the history and come back to it and ask them, how long after you start running does your knee hurt? Subliminally, they will recognize that they've been listened to during the consultation, and they'll be quite happy about it. Consent causes lots of issues, and what I'd say about consent, post-Montgomery, as you know, it's a process. You should be very clear in your communications regarding consent, and you should personalize it. That's a whole subject in itself. Some people are better at clear speaking than others, and there's probably nothing you can do really to teach it. But try and be clear with your patients and avoid jargon. Us surgeons, you know, we have to have quite a lot of self-belief to do what we do. That can spill over to arrogance. Patients don't like it. They really don't like it. Never criticize colleagues. And there are ways of telling patients that they're fat, but most of them cause complaints. So I'd probably steer clear of it most of the time. Next. So you've heard from Tim Briggs about, you know, how GIRFT is improving things. Well, the fact is that things improve on their own over time, and you know how much you can attribute to what is well, sometimes difficult to work out. I've published a fair bit with Alex Bottle, who's an epidemiologist, professor at Imperial College, and he says all processes improve over time. And there are three ways that they do. Next. So these are the giant leaps. You know, these are the inventors of the COVID vaccine, transferring their mRNA technology from cancer to vaccination. And we think this is a huge leap. You know, penicillin, John Charnley hip replacements, that sort of leap will produce improvements. Next. Yeah, this is a screenshot from the National Hip Fracture Database. So this is, again, it's what Professor Briggs is referring to. It's management consultancy is, you know, if you don't measure it, you can't improve it. So it's lots and lots of measurements, lots of competition. And if you do that, eventually that will produce an improvement. And there's been all sorts of improvements in length of stay, mortality, etc. Since the National Hip Fracture Database was introduced, best practice tariff. So measuring things, micromanaging things, I'm reluctant to say it does actually work. It does produce improvements. Next. And, you know, complaints, mistakes. If you think of something as simple as the Titanic, what improvement did the Titanic make? Well, actually, the improvement it made was that after the Titanic, the lifeboats on passenger vessels had to be able to accommodate all the passengers on the ship. And that wasn't the case before the Titanic. So there's a mega disaster producing an improvement. I think it's constructive to think of complaints that way. Complaints can make you annoyed. Someone's complaining about you or a colleague, but look at it as a way that you could improve your system. Next. A bit close to home, you probably know this guy, James Styner. He was piloting a light aircraft with his wife who died and his 3 children who are pictured with him. And they were all seriously injured, but he was well enough to triage them in the field and then got to the local hospital. The care he received in the local hospital was so bad that he was moved to set up the HLS course. And of course, that I think has produced quite a big improvement in trauma care internationally. So again, the result of a complaint or an error producing an improvement. Next. More prosaically, this is just an example from our hospital where a complaint regarding a patient who had an intraocular bleed post-surgery resulted in us unifying the thromboprophylaxis policy in ophthalmic surgery. Previously, you know, different surgeons had different ways of doing it. Of course, all that does is spread confusion. So a complaint directly resulted in an improvement. Next. So this is, I've got a couple of slides that I want to do a poll. So I'm just going to give you the scenario now. This was a case I was involved with. These are both real cases. This is a patient who complained. He had an ACL reconstruction, got infected, reoperation, outcome was bad. In the end, the graft had to be removed. So, you know, what's the correct response to this? What do you want me to do, Sonny? Do we give people 20 seconds or so to make their mind up and move on to the next?
Yeah, we'll just give another 30 seconds or so. We've got 59 respondents so far out of 103.
That'll be good, actually. So, Mark, did you want to see what the attendees' response was now?
Yes, yes, please. Yeah.
Okay, why don't we do that then?
Actually, yeah.
Carla, can we see the response?
Okay, and we'll go on to, I'll talk about the results after the next one. So go on to the next poll.
So is that a different question?
Yeah, next slide, Sonny. Next slide. Hang on. Yeah, that's it. Okay. So again, this you're all orthopedic surgeons, aren't you? So you'll understand this. This happened in our trust. I can't remember which way around it was, but we were delivered a whole load of DHSs that, let's say, were 130 degrees. And we have the 135-degree angle guide for the guide wire. And 7 of these were put in with the 130-degree guide. None of the patients came to any harm whatsoever. So that's the scenario.
Sorry, Mark, can you clarify what was the combination of events?
So we had a whole load of 130-degree DHS plates, and 7 of them were put in with the 135 guide for putting the guide wire in the femoral neck.
Okay.
Understood?
Yes. Yeah.
We'll just give it another 15 seconds.
Yeah.
Okay, we'll just end the poll there. Thank you.
Okay, so I'm going to take the first one first. It's interesting, actually. I mean, the majority of you, I feel, got it right, but a significant proportion of you, responded duty of candor apology. Now, this was a medical legal case that I got involved with, and I was asked to give an opinion as to whether there had been negligence. So what had happened, the patient had got an ACL reconstruction, was readmitted a week later. The surgeon involved came to see him personally, organized the washout, did everything beautifully, perfectly. You know, it was a recognized complication. The consent form stated infection as a possible complication. And the reason that I got involved was because the patient had sued the surgeon. And the reason the patient had sued the surgeon, as he said in his thing, was, I knew he must have done something wrong because he apologized 6 times. So just be aware of that. You know, things can go wrong, and, you know, they're a recognized complication and bad things happen. There are ways to apologize. You know, I apologize that your outcome hasn't been good, but I'm afraid this does happen sometimes, that sort of apology. But you can be over apologetic. There wasn't any, you know, the treatment throughout was completely appropriate. And, you know, there was nothing really to apologize for. So I'd say B or C were what I'm viewing as the correct answers. Now, the next one is, I think your responses were about 50-50, as I remember. And again, this is the other side of the coin. You know, these, but post-Francis, the correct answer is B. And, you know, these were 7 never events. Of course, you know, the margin of error for a DHS is probably more than 5 degrees. None of these patients had any harm whatsoever. Most of them were, you know, in nursing homes, demented, etc. all of them got called back for, harm reviews, duty of candor meetings, etc. CCG was informed. So, I mean, the correct procedure, I'm afraid, is B. Okay. And next. So now you've heard about the bad stuff, and that's a picture of the good stuff, sailing on Lake Garda. And that's the end.
Thank you for making the bad stuff so kind of closer to home, and also showing that how your years of experience help to navigate those stormy seas. That's really, really helpful. Thank you.
It's taken me a long time to accept how much you have to do over what I'd call a simple complaint. I was very worried that you were making a mountain out of a molehill, but it just is what it is, isn't it, Mark? And there are these rules stroke guidelines that you have to follow. So I think it's a matter of not trying to take it too personally, but just you have to do what you're being asked to do. And I will always apologize to my patients, and if they think that's wrong, then that's fine. But I mean, that's human nature to apologize when something has gone wrong. But there's a lot to be done these days. So as you say, it's best not to get anywhere near a complaint if you can, because it's time consuming and sleepless night inducing, whatever the problem is.
Yeah.
And you've come up with a new title. So a complainer is an improvement coach.
Exactly. That's the way to think about it.
We've got a new type of leader.
That's going to take me a while to get used to.